It's my great pleasure to introduce our sponsor, who's going to introduce this panel session. So for the City of Toronto, we have John Preece, who's the Senior Development Officer within Life Sciences for the City of Toronto. City of Toronto has been a longtime supporter of Life Science Ontario. In fact, in our original incarnation back in 1989, we started out as the Toronto Biotech Initiative, and the city was one of our first supporters early in our evolution. Since then, we've grown into the organization that we are today, but that early support really helped set us on this path in this direction. So with that, John, please welcome him and introduce our panel.
Thanks, everyone. I'll be very brief because you're not here to listen to me. So as Jason said, I'm John Preece. I handle the life sciences file for the City of Toronto. Bottom line here is if you're involved in the life sciences in Toronto, feel free to use the city as a resource. I have lots of business cards. I'm sitting right over there. So happy to talk to anybody about more or less anything. Okay, it is now my immense pleasure to introduce Ryan Wiley of Shift Health and André Picard of the Globe and Mail. Neither of these people will need a major introduction, so I'll just say Dr. Wiley heads up Shift Health, one of Canada's most respected strategy firms dedicated to serving the health and life sciences sector. And André Picard is a health columnist at the Globe and Mail, author of 5 books, winner of the award whose name I like the most, the Missioner Award for Meritorious Public Service Journalism, 8-time finalist for the National Newspaper Awards, and someone who should definitely be following on Twitter. All right, so André and Ryan, please come up.
Great. Thank you, André Picard, for joining us today. Welcome to the Policy Forum. I wanted to begin by just noting the irony and perhaps foolishness of my position in playing the journalist to one of the foremost columnists in Canada. But we'll see how this goes. Be easy on me, if you will. But today I wanted to talk a little bit on the topic, the broad topic, but important topic of how we empower the health system as a partner in innovation. Because, of course, the health system and the patients it serves are both the impetus for health innovation, but also the largest market for health innovation. And indeed, in the blueprint that Jason introduced this morning, in Pillar 4, some of the biggest, most complex elements of the blueprint, whether in terms of adoption of innovation, evaluation of innovation, access to data, really are driven by health system and health system policy and regulation. So we know, of course, that the health system is the keystone in many ways in our health innovation ecosystem, but it can also be a millstone, that weight that holds us back. So hopefully in our dialogue today, we'll get some of your insights into how it can be a stronger keystone and perhaps a lighter millstone. So I want to begin by talking a little bit at a high level around some of the systemic challenges that our health system faces. You've written a lot about the challenges we face in promoting accessible, high quality, equitable, and innovative care in this country and in this province. But 2 that really stand out over the past in your columns over the past year or so aren't really structural or even policy primarily related, namely the need for leadership in our healthcare system and the need for evidence-based, data-driven decision-making. You've mentioned that the level of investment in research in our health system, in innovation, is laughable. I think that's the word that you used. So how are leadership and our failure to harness data holding us back and hampering innovation?
Yeah, so I think we have to start by the big picture, not forget that health is not just a spending, it's not money we spend, it's an investment. So I think we forget that to start off with. It's a big economic driver. we spent $250 billion last year on healthcare. 1 in every $11 we spend in Canada is on health, so it's a big deal. Employs 1.1 million people. So we have to look at it as an industry. And in Canada, we kind of romanticize and mythologize healthcare. And I try and look at it more dispassionately. It's a business. It's not very well run. We don't get value for money, so let's fix it. That's my shtick. That's what I've been writing about for 30 years. So to me, that's the starting point. The starting point, we have to realize we don't really have medical problems in Canada. We have great healthcare workers. If you're in the right place at the right time, your care is fabulous. But we have really profound structural issues, and we have administrative issues. And that's where the leadership piece comes in. The system is really badly administered. We don't empower the bureaucrats to do stuff. It's micromanaged by politicians. The politicians, in turn, operate essentially out of fear. They fear that the public is going to vote them out of office if they do anything. And that's why there's no innovation. I think that's the short version. I often quote Joey Smallwood, people will know as the Premier of Newfoundland, the father of Confederation. He's purported to have once said that I never had a conversation about healthcare that didn't lose me votes. And I think that's really the predominant view of politicians in Canada today. They operate on fear, and you can't run a business if you're just fearful of your clients. It's a really odd dynamic. So I think that's where the leadership void comes from.
And do you think that a better use of the data that's in the system can help us to overcome some of that fear by providing the evidence to make good decisions?
I think data is useful, particularly for people like me, use it as a cudgel. But I don't think we know from all kinds of health care things like vaccination, we know that people aren't really convinced by data that much. They're convinced by emotion and by feeling. And people's feelings about healthcare in Canada are really conflicted. We really love our system because we're supposed to. Tommy Douglas is the greatest Canadian, et cetera, et cetera. But at the same time, we hate the waits and we hate the poor access, et cetera. So there's this real conflict. So I think the data can help unpack some of that, but it's not going to, the data is not going to be useful unless we use it better. And to me, one of the big things we need to do is empower the administration. When I look at other countries, I get to travel a lot in my work. If I look at European countries, what distinguishes them from us is the administrators administrate. There's not as much micromanaging. I'll give you as a journalist, we love anecdotes. I'll give you an anecdote about meeting the Dutch health minister. So I'm a big fan of the Netherlands health system. I go there often because I have a child who lives near there, and I've come to know it. And I met the Dutch health minister once, and they undertook a really dramatic change. So they were at a 100% publicly funded system, a bit like Canada, and they went to 100% public insurance with well-regulated, et cetera. Everyone has insurance. It's universal, but it's private. And this blew me away. I said, how did you do that? And he said, well, our administrators studied this issue. They found this was more cost-effective, so we implemented it. And I was like, and? And, when did the people go into the streets and lynch you and et cetera? And he said, why would they do that? It was the smart thing to do. We did it. We did what our experts told us to. And I've never heard that done in Canada. I don't see any risk-taking. I don't see any innovation because you can't have that if you operate in an environment of fear.
Of course, creating that culture of leadership and empowerment is an entirely different question. I mean, how do you build that into a system like ours?
Well, if you want to draw good people, you have to have the system that allows them to flourish, right? So we've had some great healthcare administrators in Canada. They don't tend to stay very long. I think of people like Steiny Brown in Ontario, was an assistant deputy minister, went in there with really bold ideas, didn't last that long, went back to academia. We beat people down and drive them out, we're not going to get the leadership unless we allow people to lead.
I want to focus on another gap that you've identified and raised repeatedly in some of your columns, which is Pharma Care. And you've noted that the lamentable standing of Canada's healthcare system in things like the Commonwealth Fund rankings, I think we're third last among wealthy countries. largely reflects our failure to invest in an integrated system. And part of that integrated system is public funding for medicines. And you've also commended even our provincial government on the decision to fund Pharma Care for the under 25 population, but at the same time criticized this patchwork of access to medicine programs across the country and some skepticism that governments are actually going to step up and create a Pharma Care system that makes sense. So how can Pharma Care in this environment be a win for a cash-strapped government and be a real driver of innovation in the health ecosystem?
Right, so I think the starting point has to be we have to define what we mean by Pharma Care. So there's a lot of discussion today, and it means many things to different groups. It means one thing to unions, it means one thing to employers, et cetera. So let's figure out what we mean. And to me, Pharma Care means providing essential medications to everyone who needs them without a financial burden. So it doesn't mean free, everything's free. It doesn't mean everything's covered. So it has to be a middle ground. And again, I look to other countries. Again, what distinguishes us in Canada from all other European countries, developed countries, is we have this weird system where it's called, the academics call it a bifurcated system. So we cover 100% of physicians and hospitals, as we did in the 1960s. And we cover various amounts of everything else. So about 45% of drugs are publicly covered now. So that, to me, we should cover more things more broadly. I like to use the metaphor of a basket. So the Medicare basket of services now is very narrow and very deep, has hospitals and doctors in it. And it should be a lot wider and a lot more shallow, again, like other countries. So cover, say, France or the Netherlands, Sweden, they cover 80% of everything, from dental care through to physicians, but it's supplemented by private insurance, by out-of-pocket payments, et cetera. So we'll come back to the Pharma Care question. So right now we have, at the last time I counted, 102 public programs for providing drugs. We don't have one, it's a mishmash, it's a mess. I think in a recent column I called it an unholy mess, is what it is. So we tend to cover seniors, but not in every province. So seniors tend to be covered. There's some user fees in some province, et cetera. Increasingly, we're covering children. Ontario's brought in, I call it kiddie Pharma Care. So we're going to cover drug costs for kids or young people up to age 25. But then that middle ground, nobody really covers. So why from 25 to 65 do we have no drug coverage? In Canada, we tend to depend on employers to do that. And again, it's hit and miss. Depends who you work for, what the plan is. And employers are increasingly pulling out. More people are self-employed. So that the unfairness and the void is getting bigger. So we have to bring some sense to this and some logic. And I don't know exactly what the one solution is, but I think it's some sort of, not a federal program. I don't think there's any appetite for that, for any one given program, but some kind of national standards that ensure that everyone gets coverage. So I live in Quebec. In Quebec, we have Pharma Care, in quotes, which means everybody has drug coverage. If you're employed like I am, it's an obligation for my employer to give me drug coverage. If I was not employed, I could purchase it from the government. If I was low income, it would be provided. So everyone's technically covered. Now, I wouldn't hold out Quebec as a model because it has a lot of problems, but it's a good structure philosophically, if nothing else.
And is it, in your view, can it be, or is it naturally a good structure to support innovation within the ecosystem?
Well, again, it depends on the devil is always in the details, right? So if you have a good program that provides necessary drugs to everyone, I think there's going to be more sensible spending. I think the spending, I think there's a lot of benefits for Pharma Care for industry that we forget about. Industry is not opposed to Pharma Care, depending on how you define it. Central buying, we're talking a lot about. That would make sense. No pharma company wants reps in 13 different jurisdictions. It's a waste. That's what we have now. So if we could bring some order to that. But to me, affordable drugs doesn't or fair drug pricing doesn't necessarily mean cheap drug pricing. It has to be fair. There has to be a reward for innovating, for investing, et cetera. We have to find that middle ground. And I know we'll talk about this a little more, but the way we price drugs now is, again, a bit out of date and nonsensical. And
that's where I want to go now, actually, because you have criticized our approach Canada's approach to assessing the value of innovative technologies and pricing those technologies, noting that the Patent Medicine Pricing Review Board and its benchmark 7 countries results in some of the highest drug costs in the world. And you've also noticed, without realizing the level of industry investment in research that it was designed to foster, but at the same time, of course, industry has quite legitimately grown frustrated with a very antiquated system of calculating R&D investment, a system that was created 30 years ago, and has expressed growing concern that the way in which we value innovation does not take into consideration the larger socioeconomic benefits of that innovation. So, I mean, it's a big question, but what is needed to ensure that our approach to adopting new technologies into our healthcare system drives investment in innovation while ensuring value for money?
Yeah, so I think, it has to be said that I think there's some value in benchmarking. All countries do it, except the US. And the question really is, what are the fair benchmarks? What's fair for consumers? What's fair for industry? What's that middle ground? And I think in Canada, we have a reputation as sort of being pragmatic on things, and I think that's something that would serve us well in the drug field. As you noted, in this audience, we don't have to lay out the background well. People know it, but the PMPRB 7, when it was brought in, was a good idea. We brought in patent protections. But the world has changed a lot since 1987, right? It's not the same world. We chose those 7 countries because they had high R&D investments. We assumed if we price exactly like them, we'll also have high R&D investments. That didn't turn out to be the case. We realized, which we probably should have realized beforehand, that there are other factors that matter. You have to have a good location for companies. You have to have good clinical trials infrastructure. And you have to have good government investment in R&D. And I think that's, to be blunt, that's where we screwed ourselves. We underinvest publicly, so why would industry invest here? Then there's the debate you brought up about how much does industry invest? And we could fight about mathematical formulas all day. The federal government is getting a lot of political capital going around these days, saying industry only invests under less than 5%, I mean 4.5. Industry has just put out a report, Innovative Medicines Canada, saying it's 9.9%. Being a Canadian, the truth is probably somewhere in the middle there. So let's say it's 7%. Is that good enough? Maybe, maybe not. But let's negotiate it. If it's not enough, what do we want in return? But we can't, I think the problem with the public discourse is we're saying, well, we don't want to pay anything for drugs, but we also want you to invest more. I think there's an inherent contradiction there that regardless of where you're on the political spectrum, I think people can figure out that doesn't sound fair. Maybe if I'm an academic who votes for the NDP, maybe all I care about is the prices. Screw industry, fine, but have that position publicly, but be honest about it. And then at the other end, maybe the industry says, we want higher prices, we'll get more jobs. Well, prove it. And the track record isn't fabulous in that count, but it's complicated by the fact the whole industry is melting down around the world. So I think it's hard to get a fair take on what the level of investment should be. And when I write, I try to have that pragmatic view, try to give a bit of the both sides, but that way everyone hates me equally.
Well, I think that's a really important point about how do we have an honest dialogue between or with the sector and with policymakers, particularly in an environment where the provincial and federal governments have both made science and innovation sort of touchstones of their agendas, and lots of things have been done to support that. Most recently, the Office of the Chief Health Innovation Strategist in Ontario. Both levels of government have appointed chief science advisors. But as we discussed earlier today, there's been a notable number of disappointments, including in the recently announced superclusters. So how can, in your view, our sector be a more effective partner in that dialogue, in setting an agenda that favors health and life sciences innovation in this country, particularly as Dr. Stoykert and Niemer assume their positions, and how do we sort of interface with those offices?
Yeah, so to me, you said in passing, the government has done a lot. I'm not convinced of that. What I've seen is a lot of gestures. Now, gestures are not policy. So I think what has to happen is these gestures, it's great that we have new science, chief science officers, but follow it up with some concrete action. So as you mentioned before, I've written very critically about the fact that our health dollars, 1.5% of our health dollars go to research, $3.6 billion last year. Again, when we take the romanticizing out, if we treat healthcare as an industry, what industry invests 1.5% in R&D? None that remains in business, none that innovates, none that serves its customers. And it's that we get the results we invest for in Canada. We get no results. So, let's at least, if we're not going to be hypocritical about it, if we say that the pharma industry is spending 5%, let's start there. And we want them to spend 7%, well, let's spend 7%. Let's, put our money where our mouth is. And so that's what bothers me. I like these gestures, they're nice, but where's the action behind it? The Naylor report, people in this audience will know what the Naylor report is on reforming federal funding. I think that has to be essentially implemented in its entirety. The problem we have with doing reports in Canada, and one thing I have to note that we do better than any country in the world is study our health system. we don't act on it very well, but I wrote, not my most recent book, but my second last book was essentially a history of Medicare. And I went back and I read 40 different national examinations of Medicare and what was wrong. 40. And then I charted out what was implemented, and it was virtually nothing. So the problem we have when we have reports is we cherry pick. And if you cherry pick a report, it's almost as bad as not having done it. So I think something, the gesture I'd like to see is, listen, we're going to take Naylor and we're going to implement it. We're going to get this whole mishmash of 45 councils or whatever we have, and we're going to make it sensible. We're going to have one or two, have the tri-council or whatever you want to call it, and we're going to do it sensibly. So you got to move beyond the gestures, I guess is the short version.
Do you think Naylor will be implemented?
Again, there's lots of whispering from the government that stuff is coming, watch the budget, etc. I fear, knowing my history, that part of the Naylor report will be implemented. So hopefully the best parts will be implemented, but I don't think that's enough. We're still going to limp along. I don't think we're going to get to, we're at 1.5. I don't think we're going to magically be at 5% overnight, but hopefully there'll be some movement and some commitment to it.
I have one final question before opening it up to questions from the audience. We'll have about 10 minutes, but you've mentioned a couple of benchmarks, Netherlands most notably. Are there other health systems around the globe that you'd turn to as exemplars that we can learn from?
Yeah, I think we have to avoid that saying, oh, the magical solution is we should be France, or the Netherlands or whatever, or Germany, depending on what we think. I think we have to recognize that health is really deeply embedded in our culture. That's why I wrote a whole book about Medicare history, because I don't think you can understand what's wrong with our system unless we understand how we got here. And we have a lot of quirky things about our system. Our health system was essentially founded by religious movements, and to this day, it's our religion. And we have Spartan facilities because we have this belief that healthcare should be charitable and not profitable. These are all really deeply ingrained cultural views in Canada that you can't magically change by importing. But I think all health systems can learn from each other. And the big lessons we can take is the one I said before, is that let's decide what we want, what's essential, and fund that publicly, and then figure out how to supplement that. We have this fantasy in Canada that we have a free healthcare system. In fact, we have the highest private spending in the developed world aside from the US. So 30% of our spending is private. I'm not opposed to private spending, but I'm opposed to irrational distribution of spending. So there's too much private spending in some areas like home care and dental care, and there's too little in other areas like hospitals and physicians. So I think we have to bring some order and some logic to that, and that's what we can learn from other countries. And we can learn value for money, having goals. what is the goal of Canada's Medicare system? There's no mission statement. There's no annual public health goals. Like in Sweden, I read every year in January, here's the 10 goals they had for the last year, which were achieved, and the ones that were not, here's who got fired. They didn't achieve their goals. That's the reality there. They don't mess around. And we don't have any goals, so we never fail in Canada because we never have any goals and we never take any risks. So I often go around when I get to speak to students, I say, listen, go out there and fail. You know, we could do with a lot more failure because every successful company, every successful industry has a lot of failure.
I want to open it up to the audience for questions. I'm sure that you've stimulated a lot of thinking. Yes, Jason. Of course, Jason. I should just go there first, really.
Brian, you should just leave the mic here, really. So first of all, Andre, thank you so much. Very, very thoughtful responses to some great questions, Ryan. Recently in Ontario, we have a new office that was created, and that was of the Chief Health Innovation Strategist. The position was talked about for a very long time and then came into being. But really, I view this as very positive. I think Bill Chernetsky is doing a fantastic job, but his mandate is somewhat limited in scope and in resourcing. So hearing about your views on the overarching healthcare system in Canada, would a post like that has a broader mandate and significant resources behind it, and maybe with a national scope, be able to implement some of these fundamental changes that you're speaking to? And if not that, then what?
Yeah, so I'm not sure that we need another post, another person telling us what we need to do. I think we know what we need to do. As I said in this, if you go through these 40 national reports going back to 1964, they all essentially say the same thing. And in my book, I summarize them in 5 paragraphs. Here's what we said over 40 years, the exact same things over and over. Fix primary care, bring in Pharma Care, treat people where they live in the community, make quality the number one priority, not volume, which is a problem with the way we fund, and pay a lot more attention to what matters to our health, not just providing sickness care, but providing people with housing, education, a sound environment, what actually keeps them healthy instead of just trying to fix them when they're sick. So those are the 5 things that have been said over and over. So that's where we need the innovation in those 5 areas. I think we do innovate a lot in our healthcare system, but we do it on a small scale. Monique Bégin, the health minister, once said, Canada is the land of pilot projects. And it's very true. We do these wonderful pilot projects over and over again. We solve problems, and then we never scale them up. We export our brilliant ideas. Countries like Belgium, Sweden, they implemented the Lalonde report from 1974 almost in its entirety. Canada didn't do it. They have much better health systems than we do today, more cost efficient, et cetera, et cetera. So the innovation is there. I think we have to unshackle the administration, restructure the system to allow the innovation to flourish, but it's there. So I'm not sure it's a top-down approach is what we need. We need to get out of people's way. And a lot of our system gets in people's way. I was talking to health management students at Ryerson last night, and I was saying to them, you know, the average nurse in Canada today spends 60% of her time with paper and 40% of her time with patients. It's absurd. It's an obscenity. You know, we should have data entry clerks. We should have secretaries. We don't invest in that. We take well-paid people and we make them do mundane tasks, and it's not a good way to run a business. Sorry for the rant. Oh.
Other questions? Any further final comments, Andre?
Well, what else do you want to talk about? We go on and on and on.
No, I think it's been.
No, I think you know, the final comment I'll make is because whenever I get a public forum and I can get invited a lot of places, I always think it's important to emphasize what I said in passing at the beginning. We do provide fabulous health care in Canada. 90% of the people get great care. The new emergency room data came out yesterday. 90% of the people get treated promptly. But the 10% who don't, they can wait 36 hours on average if you're in that 90th percentile. That is inhumane. So we have to work on that, on the margins. We have a lot of work to do on the margins, but we have to be careful not to throw the baby out with the bathwater. So I always stress that let's not forget that we treat most people well, but we have to fix the structure, we have to fix the administration to make it easy for our caregivers to care and make it easier for our taxpayers and our patients to get the prompt care that they want. Because ultimately that's what people want. They want prompt, accessible care that's affordable and necessary. That's what Medicare is all about. And we do a lot of that most of the time, but most of the time it's not good enough.
We have a question, sorry.
You and I both have the position of reflecting over the last 20, 30 years. Good things happen with patent reinstitution. The industry was supposed to commit, 10%. They've all fell short in research. The pricing of generics, because generic companies are very strong in Canada historically, have commanded high prices. We both can tell stories about how that came to be. Generic prices are now coming down, but we're still have the highest generic prices in Canada. When you look at all those factors that have happened to present day and the need for Pharma Care, and I totally agree, what importance would you put to the lack of a domestic, innovative pharmaceutical industry in Canada as a component of the problems that we have today? You see that as a factor?
I think it is a factor, but I think we have to realize, we're a small country, relatively speaking. We're beside a behemoth. Being beside the U.S., the elephant is there. I think that has a real influence more than anything else. So having a domestic structure, I think that's important. I think we have, for example, a really good clinical trials system in Canada. We don't talk about that enough. That's a real success. It draws attention. So I think what we have to do is play to our strengths. I don't think we do that enough. We, to me, often try to be a mini U.S., right? Oh, if the U.S. can do it, we can do it too. Well, not necessarily. It's a different culture, different attitude there. Let's find our strengths. The way Switzerland has done, or Germany, they really play to their strengths. And I think Canada, it's maybe the Canadian thing, but I think there's a certain level of insecurity there that's reflected in our structure, in our corporate structure, and our expectations. Hope that's not too philosophical.
I have a question here. What's your feelings on the, the preventative side of the health industry, where you're not doing post-sickness, but before sickness? What's your thoughts on that?
Well, I can tell you that we spend 96% of our dollars on sickness care and 4% on public health, on prevention. So is that a good balance? I think everyone would recognize that it's not. That being said, this notion that magically, we can keep people from getting sick, it's a little more complex than that. And to me, the investment, it has to be a little better investment in public health, but I think there especially has to be better investments in education. We know that the single biggest factor to people's health is their income. So we need a sound economy. We don't talk about that. That's really essential to people's health. If you want people to have good jobs, they have to have a good education. That has to start, when we have toddlers. So what do the countries who have really healthy populations have? They have really big investments in childhood development, in daycare, stuff like that. All that pays off later, but it doesn't have an immediate political payback. And again, I come back to, if we have a system that's micromanaged by politicians, that depends on 2-year or 4-year election cycles, we're never going to get vision. So, I unshackle that a bit, have some more thoughtful long-term policy, and I think we'll get more bang from the buck. But, the answer isn't, my public health friends won't like this, but the answer isn't putting billions into public health tomorrow. That's not going to change things. It has to be a longer-term vision.
I want to push back a little on that question over there. Some of the big pharma companies in the world come from very small countries. And you've looked around the world. What's the secret sauce? I think the reason it doesn't happen in Canada is because our entrepreneurs don't know how to grow big companies. And in Finland or Switzerland or Sweden, they do. Can you shed some light on that?
Yeah, so I wasn't suggesting with that answer that we didn't have good Canadian companies and that small companies couldn't grow. I was just saying we put a lot of attention to the multinationals, and can we keep Pfizer in Dorval, for et cetera? We obsess about that more than...
No, we could use some $100 million and $500 million companies. Who needs $1 billion? I agree with that.
But on the innovation side, I'll tell you, I'm not an expert in this area, but I'll tell you what I hear. I spend my life at conferences, meet a lot of young people. Every conference I go to, somebody approaches me and says, I've got this great innovation, and you know what? I've got investors from the US. I can't get anything in Canada, so I'm moving. I'm moving to Palo Alto. I'm moving to Boston, to the innovation hub there, and I'm going to grow my idea. And then later on, I'll try and get into the Canadian market if it's worth the bother, which it may not be. So I think we really do a bad job of, it comes back to that public investment, 1.5%. Do we encourage innovation? Do we nurture young people? Do we buy their products? I don't have to tell this room, if you have a new innovative product, I've heard this 1,000 times from people, and you approach the Ontario government, forget it. It's not going to happen, right? They're not going to buy it. Whoa, you're not sold in the US, we're not interested. The US is interested, or Switzerland is interested. So I think, again, it comes back to this unwillingness to take chances and to take risks, and our innate small c conservatism. Well, what we have isn't great, but it could be worse, so we better not do anything. I hear that fear over and over again, this fear that, it could be worse. Maybe, but it, in all likelihood, will be better. So I think it's about giving people a leg up, investing on the ground a little more, take a little bit more risk.
One more question.
Oh, last question, excellent. I'm Mark Smithies. I'm Chair of Life Sciences Ontario. I'm also president of a small Canadian company called Labtician Thea. You have given some really tremendous and controversial at times advice to governments. You have an amazing cross-section of the business of healthcare and life sciences generally in this room. Would you have any key pieces of advice for the business side of healthcare?
Well, I think the business side, I'll tell you my frustration with the business side is that business never talks about Medicare. They talk about investment, they talk about innovation. There are two groups that Medicare, universal healthcare, benefits the most, and that's business and the middle class. Every country takes care of the poorest of the poor, in some by hook or by crook, by charity. But universal healthcare really helps the middle class, keeps them from having these undue burdens the way they do in US from funding. It really helps industry. Why does it cost $2,000 less to make a car in Canada than in the US? Because we have a public universal healthcare system instead of a massive private insurance spend on the companies the other side of the border. So that, to me, is, I'd like to hear business talk about the positives, and when they do that, I think they should offer up really good advice on how to fix the structure and how to fix the administration. If you have that credibility, I think you can do it. So when people talk about, when you say in Canada, I want more private healthcare, people, that's evil business. They just wanted profits and they're going to screw us. That impression exists because they don't talk about, hey, here's how we benefit and here's how we want to make it better. So that's not on the investment side that we've been talking about, but I think that's sort of my pet peeve. And if you do that, I think it would give more credibility. And then the other part of it is on the research side is talk about the benefits of research, and not just for industry, but for the public. Having good jobs, having these investments, having little companies flourish, that's the future of the economy, right? We're not all going to, it's not about having, everybody's not going to be an Amazon or a Google. In the future, I think increasingly it's going to be all these small companies, biotech. I'm obsessed with genomics these days. I think there's a lot of future there. Lots of hype about AI. Canada has an international population. We draw people from all over the world. We have these big brains. Let's unleash them and let them work. And I think that's what we have to do, is get the paperwork out of the way, get the fear out of the way, and open it up, take a few more risks on spending our money. It's not just about building more highways, it's about building better brains and better companies and better jobs, and that's going to pay off to our health in the long
I think with that, I think we're out of time. André Picard, thank you so much for joining us today.